All right, let's dive right in. Today, we're stepping into the world of nephrology. Now, a lot of people think it's one of the most complex fields in medicine. But what if I told you it's actually got this super clean, almost organic chemistry-like logic to it? It's not about guesswork. It's about following a very specific, very structured investigative path. We're going to crack a case today, and it's a case that starts not with a patient's story, but with cold, hard data.
And this quote basically says it all. You know, in most of medicine, you start with the patient's history, then you do an examination, and then you order tests. Well, nephrology totally flips that on its head. It's almost always investigations first, then examination, then the history. Why? Well, it's because the kidneys are kind of sneaky. They don't always give you clear clinical signs. The real story, the real clues, are buried in the lab work and the imaging. Getting that data right up front isn't just about being efficient, it's absolutely critical to avoid making some really big diagnostic mistakes.
So here's how we're going to tackle this. First, we'll look at that unique investigation-first approach. Then we'll hit the first major fork in the road, figuring out if we're dealing with chronic kidney disease. From there, we're going to follow the clues to a very specific syndrome. We'll profile our prime suspect, renal artery stenosis, uncover a really fascinating twist in how it works, and finally, we'll crack the case of secondary hypertension.
Okay, so what are the ground rules here? For any patient, and I mean any patient, where you even suspect a kidney problem, the investigation kicks off with 3 mandatory, non-negotiable tests. And these aren't just suggestions. This is the foundational toolkit.
This is our holy trinity right here. An ultrasound of the abdomen, a full panel of renal function tests. That's your urea, creatinine, electrolytes, and a complete urine analysis. Without these 3 pieces of the puzzle, you're basically flying blind. You know, there's this classic cautionary story of a doctor who spent 45 minutes taking a detailed history from a patient with a creatinine of 2, only for the ultrasound to come back later and show the patient had cervical cancer blocking both ureters. It was a completely post-renal obstructive problem that these 3 basic tests would have picked up immediately.
So with that initial data in hand, we hit our first big fork in the road. And it's a really critical one. The question is simple. Does this person have chronic kidney disease or not? This is a huge deal because the moment you label someone with CKD, the whole conversation changes. We're now talking about long-term management, dialysis, maybe even a transplant.
And of those first 3 tests, the ultrasound is really the king of the castle here. It's the fastest way to answer that CKD question. It tells us 2 vital things right away. First, the size of the kidneys, and second, what their internal structure looks like. Plus, it also immediately tells us if there's any kind of obstruction, which is a whole other diagnostic path.
Now, let's break this down. There's a key concept here called corticomedullary differentiation, or CMD. In a healthy kidney, the outer layer, the cortex, looks kind of dark on an ultrasound, and the inner part, the medulla, is brighter. This clear contrast, this differentiation, is a hallmark of a healthy kidney structure. When that beautiful distinction gets blurry and is lost, that's a huge red flag that chronic damage has been going on for a while.
So here's the bottom line. We can often diagnose CKD with a high degree of certainty just from the ultrasound. If a kidney is shrunken down, less than 8 centimeters long, that's CKD. If it's between 8 and 10 centimeters but has lost that clear CMD we just talked about, that's also CKD. Heck, even a large kidney, over 10 centimeters, can be a sign of CKD if the CMD is gone, especially in diseases like diabetes or amyloidosis that make the kidney swell up before they fail. If we see these signs, that path of our investigation, it's pretty much a closed case.
Okay, but what if it's not CKD? What if the ultrasound shows 2 perfectly normal-sized kidneys with great architecture? Well, this is where the real detective work kicks in. These are what we call the million-dollar cases, where there's an active and, more importantly, a reversible cause for the kidney problem that we have to hunt down. We're no longer ruling things out, we're actively hunting for a specific syndrome. So once CKD is off the table, we start sorting the possibilities into these different buckets, these different syndromes. We could be looking at an acute kidney injury that came on over just a few days, or something more gradual like a rapidly progressive renal failure. You can even have kidney disease with totally normal function tests like nephrotic syndrome. But for our case today, we're going to follow one very, very specific clue.
When a patient shows up with blood pressure that is through the roof and their kidneys are failing acutely, all signs are pointing to one place: the blood vessels. The problem isn't in the tiny filters or the tubules of the kidney itself, it's in the pipes, the main arteries that supply the kidney with blood. Our investigation is now zeroing in on large vessel disease.
And the #1 suspect in large vessel kidney disease is something called renal artery stenosis, or RAS. It just means a narrowing of the main artery going to the kidney. But here's the thing, RAS isn't just one bad guy. It's more like a criminal alias for a few different underlying diseases, and each one has its own distinct profile.
And this table just lays it all out so perfectly. It shows you how the patient's own profile gives us massive clues. The most common cause of RAS by far is atherosclerosis, hardening of the arteries, and that usually happens right at the beginning of the artery. But if you have a young patient, you're not thinking atherosclerosis, you're thinking of something called fibromuscular dysplasia. In a young patient of Indian or Asian descent, especially a woman, Takayasu arteritis jumps right to the top of the list. And in a young male, you might even consider polyarteritis nodosa. The patient's profile helps us build a case before we even get an angiogram.
Okay, and this is where things get really, really interesting. This is the big twist in our story. We might have a diagnosis, renal artery stenosis, but that one single problem can cause two completely different diseases. And the entire clinical picture, everything, hinges on one simple question. Is the stenosis in one kidney or is it in both?
Now, to get what's happening here, you have to understand this one key mechanism: pressure natriuresis. Think of it like the kidney's built-in safety valve. When a healthy kidney senses that blood pressure is too high, it does something brilliant. It starts dumping salt and water into the urine. That lowers the body's fluid volume, and that, in turn, brings the pressure back down. This one single mechanism is the key to this entire mystery.
So let's put it all together. On one side, you have unilateral stenosis. Just one kidney is affected. That kidney isn't getting enough blood, so it freaks out and pumps out tons of renin, which makes angiotensin II and drives blood pressure sky high. But the other kidney, the healthy one, sees this crazy high blood pressure and triggers pressure natriuresis. It dumps all the extra salt and water. So what do you get? You get a patient with severe angiotensin-driven hypertension, but their body's fluid volume is totally normal, and their kidney function is often fine. Now contrast that with bilateral disease. Both kidneys are starved for blood. They both scream for more pressure. Angiotensin II is high, but here's the crucial difference. There is no healthy kidney to perform pressure natriuresis. The body has lost its ability to get rid of salt and water. The problem is no longer just about angiotensin, it's about massive, overwhelming volume overload. And that doesn't just show up as high blood pressure, it shows up as flash pulmonary edema, fluid in the lungs, and catastrophic renal failure.
Let me tell you a story that just hammers this home. An 18-year-old girl comes into the ER, she's gasping for air, and she has severe pulmonary edema. Her blood pressure is a staggering 220/100. They do an echo of her heart, and it's normal, so this isn't a heart problem. This is a classic hypertensive emergency. And with this presentation, the culprit is almost certainly bilateral renal artery stenosis, which in her case was caused by Takayasu arteritis.
And her creatinine level, get this, it was 18.5. That is a devastatingly high number, confirming the severe acute renal failure that is the absolute hallmark of bilateral disease, where there's no healthy kidney left to save the day.
So we've got our suspect, we understand the motive. How do we actually crack the case for good? Now that we've figured out the likely syndrome and how it works, we need to follow a very specific diagnostic algorithm to prove it's RAS and, crucially, to see if it's something we can actually treat. The first tool we reach for is a renal artery Doppler ultrasound. And the logic here is just beautiful. First, we check something called the resistive index, or RI. If the RI is high, 0.8 or more, it tells us the kidney tissue itself is already badly damaged. At that point, opening up the artery won't help. But if the RI is low, we then look for signs of a blockage, like a peak blood flow velocity over 180 centimeters per second. If we see that, bingo! We've likely found our culprit, and it's time to bring in the big guns for imaging.
And you know, the Doppler can give us another little clue, this really classic, almost beautiful finding. It's a specific waveform pattern called parvus et tardus. It's Latin, and it means weak and late. Downstream from a bad narrowing, the pulse of blood becomes weak, that's parvus, and it arrives late, that's tardus. Seeing this pattern is a dead giveaway for a significant stenosis up high in the artery.
So the game plan for imaging is super clear, right? We screen with the Doppler ultrasound. To get a really good, non-invasive look at the arteries, the investigation of choice is a CT or an MR angiogram. And finally, if we're actually planning to go in and fix it with a stent, the gold standard is a conventional angiogram. That gives us a live, real-time roadmap for the procedure.
And that really brings us to the big takeaway here. The one thing I want you to remember. When a patient comes in with a hypertensive emergency, that's dangerously high blood pressure, that's already causing organ damage, the first impulse is always to ask, how do we get the pressure down? But the much more important question, the one that can save a kidney or even save a life, is why is the pressure this high? And that's why a hypertensive emergency must always be treated as a secondary and potentially reversible condition until it is definitively proven otherwise.